Good afternoon, and thank you everyone for joining ASTHO's COVID-19 Texpo-sponsored led webinar series. This is the last of our series of this, and my name is Priyanka Suryo. I'm our Senior Director for Public Health Data Modernization and Informatics here at ASTHO. And we've been hosting these webinars as informational series brought by three of our program sponsors who actually supported the COVID Texpo as additional learning opportunities for you all to continue the discussion around the various topics that were covered during our Texpo back in March of this year. We're looking forward to hearing from our partner who will be presenting today, and we'll leave some time at the end of the webinar to actually address your questions and engage in that dialogue. So during the presentation portion or at any point, you can actually submit questions using the Q&A button at the bottom of the screen, and there are some instructions in the chat as well to ask your question for our presenter. We can also bring you on the screen if you want to ask your question directly. You just have to let us know in the chat function. So today's program is covered by our premier sponsor, Chexout, and they will really be engaging us in a dialogue today around public health data modernization and a new frontier for infectious disease management. And that's the angle they're going to take and bring to the larger public health data modernization discussion. They are an infectious disease prevention and control software designed to meet the unique needs of public health and its community-based partners. Chexout was founded in 2010 and has been helping public health leaders modernize clinics and operational workflows, and they're working nationally in 14 states and a territory, county, city, and with local health departments from Hawaii to the U.S. Virgin Islands. So we'll be particularly excited to hear about that experience of theirs. It is this cloud-based software that unifies people, workflows, and data streams. The software itself, and again, our speakers will speak more to this, provides secure patient portals, unique monitoring, dynamic patient communications, clinic management, lab communications, investigation management, contact tracing, analytics, and so much more that we've seen been an emerging need during COVID-19. So early in the pandemic, as we were responding as a nation and our health agencies were responding, Chexout was selected by CDC's National Contact Tracing Pilot Program from over open competition to 50 other companies. And so they have been considered one of the more advanced surveillance investigation and contact tracing software companies available today. During the past year, Chexout's team has helped their customers adapt and respond in near real time to the COVID pandemic and quickly deploy their software, getting large teams of professionals as well as volunteer contact tracers trained and operational in a couple of weeks, which really helped advance our efficacy with the response. So today, we're actually pleased to welcome several members of the Chexout team who will provide expert insight into what public health and infectious disease management, data modernization enhancements, and their functionality, what that might mean for you and your team if you're considering implementing them during and post-pandemic as we're transitioning into a new stage here of recovery. And they'll also share tips and recommendations on how to move forward towards achieving quick wins in the short term as they've had to adapt to that during COVID, as well as longer term comprehensive strategies for upgrading systems, modernizing, et cetera. So it's my pleasure to introduce our first presenter, Jim Ivey. Jim Ivey is the co-founder and chief operating officer of Chexout. He is a serial entrepreneur, and his passion is for finding new ways to apply technology to infectious disease prevention. This has made him a driving force and lead architect of Chexout's software and an expert in the disease surveillance software itself and how that functions. He oversees many of the operations and development teams for Chexout. Without further ado, I'd like to turn it over to him to really introduce himself and our presentation today. So thank you so much, Jim, for joining us.
Thank you, Priyanka. We appreciate being here today. Let's see, one second here. So we're going to discuss, we're going to talk today on our agenda. We're going to talk about data modernization in the age of COVID. And we're going to talk about, contact tracing investigations, data modernization and some of the pitfalls to avoid and some tips and tricks that can be used. So Chexout, just add a little bit more of a finer point on Priyanka's great explanation of our company, was founded in 2010 And we started out doing results notification for public health departments. And throughout the years, our customers have constantly asked us for new features and new ways to help them modernize their clinics. And so we were always building new software, always building new features. In January of 2020, just in time for COVID, we launched our new platform, and it was a total rebuild from scratch, because we understand that modernization requires more than just slapping some patches on old software or adding a couple new features to an existing platform, because you still have the old architecture underneath, right? And what we wanted to do was start with fresh architecture that has the newest philosophies and ways of thinking. And that allows us to be more reactive and to be able to embrace change and meet a lot of the needs of our customers in various ways. So what is needed in modern public health software? Your software, in my opinion, should support multiple program areas and rapidly configure new infections. It doesn't help you if you have a software for TB and one for STD, HIV, and then one for COVID, and then one for general infectious diseases. You should have a software that can cover all of your program areas and bring all that data together. Also, it needs to be able to rapidly configure for new infections. We saw that in COVID, where it was just a mad dash trying to find software that could replace some of these electronic disease surveillance systems that couldn't handle the volume of COVID. So that brings me into my next point, which is scalability. This is critical, we found in COVID, because your software needs to be able to scale, not just for your workforce, but also your transfer mechanisms, right? We saw health departments going from a few hundred DIS to thousands of contact tracers, and their workforce just massively expanded. So you need to be able to expand with that. Also, being able to support working remotely. We found that a lot of electronic disease surveillance systems were crashing because they couldn't take more than a few hundred lab reports an hour, and they needed to be able to take tens of thousands an hour. So those are areas where it's very, very important to have that scalability. And then you also need, like we talked about with the new architecture, you need to be able to adapt to new requirements and feature development and emerging technologies. There's always something new coming out that can be used. And if your software's got its feet stuck in the sand and it's old and it's monolithic, you're not going to be able to move at the rate that our requirements change and technology evolves. And then this one is just common sense. Be data agnostic, right? And your software should play nice with others. It doesn't matter if it's a state electronic disease surveillance system is fully integrated. You have to work with other data systems. So playing nice and being able to take different formats, and work in an ecosystem is very important to interoperability, which is something that we all are striving to achieve. So what should an infectious disease platform look like post-COVID? This is where I think that having a multifunctional, fully integrated system from the clinic to contact tracing and surveillance is critical to efficiency and being able to aggressively attack outbreaks and infections and try to control the diseases in our communities, right? So one of the things that I think is really important, I've noticed a lot of health departments having a problem with, is their clinic management software is in the EHR, but it doesn't run their outreach testing because it can't go out to the field. You should be able to pick up a tablet from your office and walk out into the field, go to the library, go to a bar, go wherever you're doing your community testing. It should all be one system. And that system should also be integrated with your investigation management and contact tracing software, so you don't have different databases with information. And if you have a patient at the clinic that they have symptoms of syphilis, right? You can go ahead and start your investigation right then. You can start your contact tracing, have it all in the system, and then send it off to somebody else for follow-up. And we found during COVID that outbreak management was critical. So I believe that this is one of the most important features that any software system can have that you're going to use for infectious disease management. And outbreak management should be predictive. It should allow you to have a library of places in your in your city or in your state. You should be able to have it aggregate how many people have named a place and then alert certain staff, right? There's a lot to outbreak management. We're going to talk a little bit more about that later. Symptom monitoring, something that should also just be in the software, sending out surveys to the patients. And then, automated, having a communication suite is critical, because You should be able to text patients, email patients, and you shouldn't be locked into your vendor's VoIP. They should be flexible enough to allow you to use your own VoIP if you already have one. I hear a lot of horror stories from health departments about their software not being able to handle ELRs, or you can't order from their labs, so they're manually putting into the lab interface. That's just a core feature of any modern system. And I do believe that results and educational material delivery via patient portal is very important as well. Now, I know that EPIs love to take their data and run and slice and dice it their own way, but every system should have some level of visual analytics. And we believe that cluster diagrams automated by the system are critical to being able to view your entire investigation and identify individuals who you may need to spend more attention on to get them into care, or important to how that the infections are spreading, right? Now, we found in COVID that, especially during COVID, workforce management became something that we needed in our electronic disease surveillance systems. It's one thing when you have 100 DIS or maybe 200. It's a different thing when you have 2,500 or 3,000 or 5,000, right? So the software should have the ability to manage workforce on-site and off-site and working from home or remotely. We talked a little bit about interoperability with other data systems. You should be able to take HL7, version 2, FHIR, XML, CSV. You got to be data agnostic. Also, the software, in my opinion, should be able to work as a hub for your other systems, and also a hub for your community partners, so that the software can take in information from your public health laboratory, parse that information, and then make it available to your community partners who may not have technology capable of setting up electronic file transfer with your public health laboratory. And then, of course, reporting to state and federal systems is a must-have. So what are some pitfalls to avoid, right? I think one of the big pitfalls to avoid is open source software that only performs one function or several poorly, right? You don't want to have a whole bunch of kludgy systems put together that don't communicate well with each other and weren't designed to work together. So sometimes when you get these open source software, it sounds great because it's free, but free also comes with some problems, like it's now your responsibility to try to take this and make it work with your other systems. And oftentimes I've heard from customers that it ends up costing them more in the long run through lost hours and through their own internal time spent on it. We also like to avoid legacy systems reworked for yesterday's needs. I talked a little bit about this for the reason why we built from scratch. And it's because just slapping some new features on an old piece of software is not data modernization, right? Because you still have that old architecture. And we'd also like to avoid systems that require your staff to perform critical functions outside the platform. And that drives having to do multiple entries. So, over the years, I've talked to hundreds of DIS, and most have the same complaint. They're entering information into 4 different systems. None of the 4 systems takes the same set of information, and none of the 4 systems takes all the information they need to conduct their investigations and do reporting. So whatever software system you choose to modernize with needs to perform every function and not have any of your staff feeling like they need to go outside of the software to collect information. We'd also suggest avoiding systems that are still in big build mode, or big box software not tailored for infectious disease management. And what I mean here is, a lot of times we'll see like an EHR or that was built for a hospital system that is trying to bring that and make it fit into public health. Or we see a customer relationship management software that is trying to take that way of thinking and turn it into contact tracing and investigation software. So avoiding systems that weren't built for public health is a pretty big pitfall that I think that we should all avoid. Any system you choose should have been designed from the beginning for your functions. So COVID-19 tales from the trenches. I got some stories today. West Virginia needed our software in May of 2020, and we only had 30 days lead time to get some critical customizations in place and to give them the capability to scale their workforce to 1,000 contact tracers working remotely. And we also had to accept, distribute, and utilize thousands of ELRs and patient interactions an hour, which their current EDSS couldn't handle. So now that we've been working with West Virginia for a while, we've continued evolving their software the overall plan here is for Chexout to replace West Virginia EDS in all of their program areas. Indianapolis is another one great example of having to deploy in crunch time. They purchased a software with the NCAA basketball tournament fast approaching, and they needed us to work as a data hub for their other data systems. And that includes their public health laboratory, the state's MS Dynamics system, another third-party vendor, and we had to do it all in 23 days. So we met that deadline, and now we're working with them, kind of very similar to West Virginia, where we're now moving in and moving to replace their existing systems and all of their other program areas. And then Philadelphia is one I always like to talk about because this is a great example of how modernized software can be flexible and can be utilized to meet needs that are constantly evolving, right? So Philadelphia already had a very well-defined ecosystem of software that available. And they called us because they needed us to fill gaps that their current vendors couldn't fill because their software wasn't able to be flexible and to be adapted. So we adapted Chexout to run their mobile COVID testing vans, and we included online appointment scheduling for each van so that individuals could choose the one closest to them. We do immunization appointment reminders for the immunization program because their immunization software doesn't do reminders, right? And now we are running their mobile vaccination vans, helping them get out in the community and get more of the community vaccinated. So I think those are three really good examples of different ways that modern software can be utilized and can be customized quickly to meet different requirements. So outbreak management is one subject I really like to talk about because it became so important to how we responded to COVID. And it's going to be very important to how we respond to syphilis and the other infections now that our STD clinics are reopening. So a system that you have outbreak management in should be able to collect places reported by patients and contacts, like I said earlier, automatically aggregate system-wide or by cluster, and automatically notify your staff when it finds a potential outbreak. You should be able to view location-based outbreaks by zip code, heat map, line list, and then easily upload massive amounts of patients to that location-based outbreak. For instance, if you had like a meat packing facility, you don't want to have to sit down and type in 2,500 people's names and address information. That's crazy. You should also be able to take all these functions and have an outbreak manager role with a custom dashboard that allows you to view emerging, potential outbreaks, outbreaks that are growing, outbreaks that are smaller. You should be able to identify outbreaks by community or communal settings. There's a lot of tools that can be given to an outbreak manager role or to a supervisor role to help us identify outbreaks. And then I think it's very important. You should be able to drill down to the exact time an index patient was at a location like a gym or a bar so that you can accurately filter potentially exposed individuals, and we can make sure that we're most effectively deploying our limited resources in public health, right? I want to talk a little bit about modernized investigations and contact tracing. I've got my cool little cluster diagram here. It's a little small, don't worry, because in a minute, I'm gonna show you the real live dynamic active one. So we know that investigations can start from, unfortunately, a fax or a phone call from a provider or, an out-of-state referral, an ELR. There's a dozen ways that an investigation can start. And my suggestion is for modernized software, your software should handle every single scenario, take that information, automatically populate your investigations, and then give you the ability to set rules on automatically assigning those investigations to the appropriate DIS or contact tracers. That's my first bullet here too, auto assignment of investigations. So we have a customer that they have 12 different working groups for COVID. They have one for long-term care facilities, one for K through 12, one for college students, one for incarcerated persons. You can go on forever. But we use patient demographics to decide which investigation gets sent to which working group, and then it gets assigned out to the DIS from that point. So auto assignment can save hundreds of hours a week in time because, let the software do the work, right? Patient communications, we already talked about that, but I think that, you having communications in your software is critical because you can, you keep everything in one place, right? And you have a list of all the people you contacted, what you said. It's very important. You need to be able to build a library of places like we talked about for outbreak management. And you need to easily be able to collect reported contacts by referral basis and any information the index patient can provide you on where to find or locate this contact of theirs, right? So my view is that once you make that contact, a page should open and allow you to collect any information the index patient has to help you with your investigation. And then that should automatically populate if it becomes an investigation. Cluster diagrams we talked about, predictive location-based outbreak management we talked about. And then also, a lot of health departments were adding on symptom monitoring as like a side piece. That should already be in the software, right? You don't need to have one-offs surrounding your core software. So I think that should be there. And then the last thing I'm going to talk about, we talked about patient communications, but there's a couple things that I would want in my communications platform. Automated results notification via text or email, automated messaging to the patient saying contact the clinic. A study, CDC funded a study of our software in North Carolina and Louisiana. And the study found that using our messaging system reduced time to treatment to 2.6 days. So it's incredibly effective. And the software should also be able to continue to message those patients until they contact the clinic automatically so that your DIS aren't having to make Excel docs trying to figure out who they've talked to and who they haven't. And then the last thing that I think really closes the loop on having a fully integrated system is modernized clinic management with online appointment scheduling, demographic information can be put in online, risk assessments, all that's available to the clinician when they go to do e-charting. You should have specific e-charting with public health specific risk assessments. You should have lab management, and your outreach testing should also be included. So that's the last piece from managing the clinics to the contact tracing to surveillance to reporting. So I'm going to introduce Deb and hand it over to Deb here. Deb is responsible for managing all client projects, ensuring client requirements are met, direct reports, as well as serving as Scrum Master for all client engagements. As a servant leader, Deb brings over 25 years of career experience. She brings a sense of humor and unique experiences from various industries. Deb is a warm, friendly person who brings a positive attitude and uses her professional experiences as a guide to assist and mentor team members throughout the Chexout project lifestyle. And Deb, I'm going to go ahead and hand it off to you.
Thanks, Jim. Hello, everyone. I'd like to talk a bit about why it's so important that we proactively work together to achieve client goals. Data modernization isn't just about technology. It's also about working with people and establishing an understanding of your workflow processes. Chexout has an out-of-the-box starting point, and every client has a unique workflow, which plays a big role in the data modernization process. We can all agree that a one-size solution does not fit all. So the first step in any company's deployment process, in our opinion, should be to understand your workflows and program goals so that you can work together to define the best set of requirements that precisely meets your needs. 10 years of working with public health customers gives us a unique perspective into your workflows, which makes it easier to communicate in the same languages. Here at Chexout, we are an agile-centric technology company, and we use this discipline throughout all our work processes. Agile allows for incremental software delivery of features and functionality over time, right? So this is an ideal way, in our perspective, to manage initial critical items, short and long-term development goals simultaneously. An example of this, as Jim mentioned previously, is Indianapolis. We were able to deploy working software within an aggressive timeline of 23 days using the Agile framework, which allowed us the ability to meet the client's deadline for the NCAA basketball tournament. If the pandemic has taught us anything, it's public health needs to rapidly modernize data systems. Technology partners must adopt standards like Agile to build systems specifically designed to be flexible and easily adopt emerging technologies. So before I hand it back over to Jim, I'd just like to close by saying that data modernization is not just about addressing technological challenges. It's about bringing together a system of principles and values geared towards ensuring that the client's needs are met in an ever-evolving healthcare environment. When you're assessing your data modernization process for your organization, my advice is to look to companies that provide a collaborative level of service with software that is easily deployable and, most importantly, flexible to meet your changing needs. I mean, who can argue with that? Thank you. Back to you, Jim.
Thanks, Deb. Thanks, Deb. I'm going to show everybody a quick demo. I promise it's gonna be like 5 minutes, but if you would like a more in-depth demo of the software, I'm happy to set one up anytime. My contact info is somewhere in here, and it's jimivey@chexout.com. But we're gonna talk quickly about working collaboratively, having a single platform for all functions. I'm gonna show you what patient communication should look like, cluster diagram, and I'll show you our outbreak module. So collaborative work is very important. And I believe that any modern software system should have the ability for team members anywhere in the state to be able to communicate with each other if they're working on the same clusters or the same investigations, helping each other. You should also be able to send communications in the software to ask for things like a regional epi to review an investigation, or a state epi or a supervisor to take a look, or to send just a question that you need help with an investigation. So we have our task box that allows for that kind of communication so that we can work collaboratively. I also want to point out that, because it's one big software system and it's fully integrated, everything that you can need from the clinic level and outreach testing all the way to your surveillance and reporting is all right here available to you. And things can be brought forward and hidden, access given and taken, all based on roles, right? So role-based access. So we have, visits, we have our incoming files, which is, think of it like an inbox for all of your ELRs. We have our investigations tab, contacts. We have our DIS tab for workforce management, analytics, and we have our outbreaks tab. So everything is here integrated so that everything works together seamlessly. Now I'm going to show you what patient communication should look like. We have our integrated RingCentral VoIP. Like I said, any new software should allow you to choose your VoIP vendor. They should be flexible enough. I'm going to go ahead and pop in here to Chris Evans, Mr. Captain America. And I'm going to jump down to our communications tab. And we can see that we can send text messages. You can have templates so that you can standardize your messaging. You can send text with your phone number or your name in it. That reduces the probability that a patient's going to ignore your phone call. You can send emails, log calls, log visits, call the patient, and everything gets logged. And any automated notifications, like the Chexout notification for follow-up that lets the patient know that you're going to reach out to them, are all here. And it also lets you know whether or not the message was sent successfully. So this is what I believe a modern communications model should look like for public health software. I'm going to jump down to my contacts, and we can see some contacts here that I've loaded for Captain America. And we can open it up, see specific information, including contact history, without having to go digging into the actual patient record. And I can view my cluster diagram right from here. And the cluster diagram will show you your referral methods. It's also color-coded to let you know the test outcomes that the patient has had. And it is dynamic, where you can mouse over and see information, or you can click it open. I can jump into Tessa Thompson's investigation right from here. I could call her from here. I can email from here. And you can also see important things, like in the case of COVID, knowing that a patient had an HIV infection, is important because they're immunocompromised, right? So the software will tell you that, yes, Tessa Thompson had a positive HIV test 10 years ago, and it was 6 days ago that she had a positive COVID-19 test. So we think that this is critical for being able to visualize investigations and to quickly work through them. And then I'm going to show you my outbreak module. The outbreak module allows you to see all the different outbreaks that you're working at one time. You can open it up. You can see links to investigations. You can see links to contacts. It will also allow you to aggregate across the entire system how many people have named a place all the way down to the hour if you want to get that specific. And it will also alert you if a certain number of people name a certain place during a certain time frame, right? So that we can have the software doing the counting in the background and not our DIS and supervisors. So that's my quick demo here. Promise it wouldn't be long, but I'm happy to do demos for anybody who's interested. And I'm ready to move on to the Q&A. I'm going to pass it back to you, Priyanka.
Thank you so much, Jim and Deb, for such an informative presentation and for that demo, especially at the end. I know it brought some questions for me, and I'm sure for our audience as well. So again, for the contact information, that is in the chat for everyone joining us, and you'll be able to see that there if you want to take that contact information down. But we really appreciate you outlining those needs, the pitfalls to avoid when adopting new infectious disease software, and your COVID-19 Tales from the Trench as well. So we'll now open it up with Q&A with our Chexout team to discuss implications of their work and to more broadly discuss public health data modernization. And we'll start with some questions here. Okay, so the first question that I'm seeing is whether Chexout supports any non-infectious disease use cases and could speak to that.
Yep, that's a great question. We can support any type of investigation. The software is very flexible and it allows for us to set up rules for anything that you may want to investigate. So that's a pretty easy answer there. Yep.
Great, thank you. Other questions from the audience? All right, so this is interesting. And I think when I'm asking this, I'd also be curious as to what you think, where you think the overlap is. But someone asked whether Chexout software can replace an EHR system. And if not, I would ask, or further ask you to elaborate how it intersects with that.
So we do have some customers that have left their EHRs and have gone with our clinic management software because it is specifically designed for public health. We can work with clinics from 100, 600 patients a year into the tens of thousands. It's not a problem. Anything that you can need that isn't currently in the software, the little outlying pieces that maybe your EHR have that we don't quite have yet, we're always happy to customize and bring in. So like I said, we have plenty of customers dropping their EHRs now that weren't built for public health and moving in the direction of using ours.
Thanks for that. Okay, so this is a very good question as well. And I think, and it's a two-part one. And we're getting some really good questions in the audience today. So thank you everyone for sending those in and keep doing so. So how much internal IT involvement and resources are needed to get this up and running? And I think if you could speak to that from Chexout's end as well as a health agency's end. And then the second part is what's the time frame to really get it going, or if there's a phased approach?
So from a technical standpoint, we don't need much from your internal IT department. We built the software and how we interact with our customers, like Deb was explaining, to specifically take that burden off of your team, because we know that there are never enough tech people in public health to handle all the things that are going on. So some areas that we would need to work together, it takes a few minutes to figure out how we're going to do the data transfers, not a big deal. And then talking about we host the software, so there's no problems there. We can you can host it locally if you wanted, if your state or city required that, and that's where your technical staff would become more important in the process. But once we get past all the data transfers, we really don't need to interact with your health department IT staff moving forward. And I believe the other question was about how long does it take to get up and running, right? So for instance, we have a deploy and develop cycle that we like to use. We have an out-of-the-box version, and it's our software. We built it from scratch. We're not piggybacking on some other company's platform. So we have the ability to get down into it and to do major customizations if need be. we can have a base version of the software up with some customizations in a month. But to really have it dialed in for the customer and to have their wish list items, that could take anywhere from like 3 months, I would say, you're fully functional and happy running the software. And then about 6 months is where we could start really kicking in all of those wish list items that may not have been in the software that you decided that were important to your workflows.
Great, thank you for that. A couple more questions. I think as it relates to the software itself, there are some questions around whether it can be used offline or on different platforms.
Sure. So that offline is something that we do not presently have at the moment. It is on the development list for us to do. I would maybe think of that late this year or maybe first quarter 2022, we could have that available unless a customer decided that it was critical, and then we would move that up based on their need, right? Because we're always happy, like I said, to build new features based on requirements. What was the second part of your question? I'm sorry, I lost that one.
Yeah, if it can be used offline was mainly the main piece of it, I think, and just how that works.
Oh, another platform. So we work with anything except for Internet Explorer. I hate the thing. We don't touch it. But other than that, you can use any tablet. Our browsers that we prefer are Google Chrome and Firefox, and we do support Safari.
Okay, good to know. Another question that's coming up is around the fact that you've mentioned that you've been able to customize it, that you can customize pretty easily for the customer based on the discussions that you have with them. Does that play any barriers into sharing across different entities? So if you're working with multiple states, and part of this is getting at the kind of data exchange, data sharing, and even aggregating of the data that would need to be reported at that scale. So just curious if you can speak to that.
Yeah, I really like that question because that is something that has historically been a problem for electronic disease surveillance systems, some of the legacy systems out there. Ours is a software as a service platform. So whenever we customize a feature for one of our customers, we will generally make that feature available to everybody in their next update, right? Because we want to keep everybody on the same version of the software. So when we have customers and we're hosting a software, we'll update it, maybe monthly so that you always have the newest, freshest code. And that also keeps you having, all the newest features that you could want. And then having everybody on that same code line allows us to bring forward certain features for this customer and certain features for that customer. The software was built to do that. And we can then work across state lines or county lines or however you want to set that up. As long as we're using standardized libraries, we prefer to stick with, the libraries provided by the CDC, but lots of customers like to have their own, custom libraries. We can always work that type of stuff out.
Do you have examples of that you all have engaged in?
For working across state lines or for dealing with multiple versions of the software?
I think, yeah, specific. I mean, it might help to give an example if you have one, but to clarify, at the state level, can we have all of our counties or multiple counties connected?
Yes. So what we call that scenario is parent-child. So the state will have a parent account that will allow you to see all aggregate information across your entire area of responsibility, all of your clinics, your counties. It will allow you to drill down into them and go into them, and it will also allow for reporting to flow upwards to your parent account, so that we can simplify reporting and getting data out of every clinic. And so that parent account's up here, and then we can have hundreds of children accounts underneath that can all be separated and only see their own patients. Or we can set up custom rules on, if a patient travels across county lines, should they be able to see the patient record? All of those rules for data sharing across jurisdictions are customizable.
Thanks for that. See, other questions? Those were some good initial ones, some tough questions to start out with.
So I think that one of the things that's really important to point out on the parent-child is that we can not only, we can do all of your clinics, right? All of your, HIV, STD clinics, we can bring in your TB, any clinics that you have. We can also work with your community partners. We have in Sacramento, we're about to go live with their outreach program, and they have, the outreach program, and they also have 5 community partners that work under different grants. And they're all going to be using the same software, and they're going to be able to choose, because we're going to be done with this customization here in a couple of weeks. They'll be able to choose what grant area, and then the appropriate questions will populate for those community partners, the community-based organizations, because one day they might be working off of this grant, another day they're doing outreach on that grant. So we built the software to accommodate those types of scenarios and to allow for bringing in a greater amount of the partners that we work with.
Thanks for that. I have another question here. So what does Chexout software look like working with mobile programs? And I'm not sure if the person who submitted that wants to elaborate or come on camera, but when I think of mobile programs, I think of maybe digital health or mHealth tools, as well as even if we think about COVID, the fact that we have exposure notification apps. So just curious if you can speak to how Chexout software would work or interoperate, if you will, with it.
Like you said in the description of the company, we are very data agnostic. So a scenario where we had to work with another vendor was in Indianapolis. The NCAA had purchased those little contact tracing bracelets, and that company was sending information, and we had to take that information as well and integrate it with the public health information flows that we were getting. So we can work with anything. I haven't seen where any of the exposure notification apps allow for transmitting data to public health. But if you have one that is like self-built and you have that authorization, we are happy to take that data and start driving investigations and updating investigations.
Interesting. Thank you. And thank you for that question. Other questions from our audience? I have a direct question, I guess, because part of this webinar series, as we're waiting for more questions to come in, part of the webinar series is a learning opportunity between, I think, both public health and tech and other vendor-based companies that have had so much experience in this space and really starting to bridge the gaps of knowledge and understanding, I think, from one to the other. I think on one hand, for public health, you have understanding the workflow and some of the political barriers or other barriers to implementing some of these things. And on the technical side, it's about public health being trained up enough to know how to manage the systems and know whether they're actually doing what they want them to do. So as you're hearing these questions and comments, is there anything that in this moment that we've been having the webinar that you've been learning from just what public health's priorities and needs are?
I think one of the things that has always struck me as being most important that I've learned about public health is that we need to have flexible systems, right? I've been to so many clinics and heard horror stories from DIS about all these different systems they have to work with. And it's just, it's inefficient and it's not a good way of doing business. So we sat down and decided to bring everything into one platform. Also learning, we're every day getting great feedback from customers asking for new features and new development. So every day is kind of a learning experience. I'm trying to remember, a customer had a really good idea on Tuesday, and we went ahead and put it into our development hopper. So yeah, there's always something to learn, and there's always good ideas for how we can continue to evolve.
This is actually a really nice segue. Another question that we've received is kind of about these partnerships or working with your customers. This one is specifically, it sounds like you've partnered with a number of localities. And this particular entity seems to learn from others who take the first jump. So has there been any obstacle that required you to adjust or specialize for that department or agency?
Okay, yep. Everybody has to have their own custom workflow and some of their own fields. Nobody just takes the out-of-the-box version, turns it on, and just takes it out in the field, even though you could do it, because everybody has a little bit different flavor of how they do things. For instance, the difference between San Mateo, California and Santa Clara, California are both of our long-term customers, and they both do things a little bit differently. So I do believe that we have an extreme amount of experience, if I will, on dealing with all these different ways of doing things. And that's why we launched the whole new platform from scratch, because over 10 years, we learned, oh, wow, this part of our software is not flexible enough, or this one's not going to be friendly enough. So we went back, built it from scratch so that it would have all those lessons that we learned.
And could you speak to any obstacles that you may have faced in that process?
Yep. Some of the obstacles that we face are, in COVID, I can tell you trying to get STD clinics up and running was impossible because the labs just wouldn't work with us, right? They wouldn't even return the phone call of the clinic sometimes. So there can be barriers in that regard. Also, one of the problems we found that gets in the way of modernization is sometimes health departments are politically wed or financially wed to a data system that's been in place and is no longer really helping them. But there's, not the will to change it even at the highest levels, even though everybody else in the health department and in public health knows that they need to change. So that can get in the way sometimes of moving forward.
Thanks for speaking to that. All right, other questions? We have maybe a couple more minutes for questions. And I don't know if Deb also wanted to pipe in with any thoughts that she's had as she's been hearing the Q&A, but I'm happy to welcome her as well. All right, we have another question here. So I think for this one, they would like to know a little bit more about what your support looks like when you do provide technical support or assistance to your clients. Is it mostly at the implementation launch stage, or is it throughout the entire usage?
Yep, that's a really great question. We are there for you on day one and on day 1,000, right? So we will come in, help you set up the software. Deb and the tech support team are amazing at working through issues. Mike, our CTO, gets involved often too if it's something of a highly technical nature. We offer full support, and that's why we really like to run the software in our cloud, because we can then quickly jump in and take care of any issues that may pop up or any new feature requests. So tech supports generally, we give everybody an SLA, and we never miss the timelines for resolving any type of issues that pop up. 100% support is what you can expect.
Right. And because we're an agile shop, we do deliver our software over time. This out of the box features that we have, like Jim said earlier, we will work with you, find out what your primary needs are, have some requirements sessions, because those are necessary to find out what you are in need of, and then proceed from there. And regarding support, we all are attached to our phones these days. So if there's a technical issue that happens, even on the weekends or holidays, we jump at it and we get to it, and we help to resolve the issue. So yeah, never ending, but yes, fun stuff. With regards to COVID and data modernization, I think that just having that level of support to make sure your data stays secure, and that we can troubleshoot on the fly, on a dime, works for us. So,
Deb, thank you for bringing that up. We are available whenever you need us to be available, and I can't tell you how many weekends we worked through during COVID and continue to. So you don't have to worry about us closing up shop at 5 o'clock on Friday when you have an issue you need resolved.
All right, to that point, we have one more question that I'll take here. Can you work in the field with mobile tablets and then sync that data later on?
Yeah, it's all because in the cloud, when you take the tablet into the field, it is running off of the exact same software that you have in the clinic. So there's no lag time. There's no having to wait for it to update when it gets back. You can pull down information and send up information in real time, working off of any tablet in the field. I just don't suggest using your cell phone because it's just too big a piece of software, and it's got too many tools that are more friendly towards, their cluster diagrams are more friendly towards tablets and computers.
Sounds good.
but we really don't have issues with using a mobile device. But yeah, just given the fact that, for example, the cluster diagram may be large for the data you have going through it, it might be a little lag, but no, there are no issues. And I just want to also say to the panel, public health is a passion, right? So we're all here to meet your needs, and let us know if you have any more questions.
Yeah, to that point, thanks so much, Deb and Jim. If you could just wrap up with how people can connect and reach out to you again, And any other last words to wrap us up here today?
Thanks. I really appreciate everybody coming and listening to a little bit about our vision for data modernization in public health and how we believe that systems should be fully integrated from the clinic through contact tracing and investigations and surveillance, right? If you'd like a demo or to just further continue the discussion about modernization, even if you're looking at something that doesn't apply to our software, sometimes customers will call because we end up touching so many other people's software that are sometimes outside of our scope of work. We're always happy to have a chat and tell you anything that we know. Best way to get in touch with me to set up a demo would be Jim Ivey, that's IVEY, at Chexout.com, or you go to info@chexout.com. I think we also have our phone number in here. My direct line is 540-270-9960, or you call the office at 800-473-1888.
Okay, well, thank you again to Chexout. We appreciate all of the insights you shared today about your software, showing us the demo, and really participating in what was a robust Q&A session. We really appreciate all the things that you all are doing to meet the needs of public health and community-based partners. And we thank all of our participants for making time to join and learn with us today throughout this series of sessions. All 3 recordings from the Texpo webinar series will be made available on our Texpo sponsor page within the next week or so. If you do have questions, comments, or feedback that you'd like to share with us following today's event, you can reach out to informatics@asthO.org. That's on this last slide here. We really thank all of our partners, and again, Chexout today for presenting. And again, if you have any questions, all of that information is located in the chat. Thank you everyone for joining us.